in the Gonstead system, but in chiropractic in general, there's a lot of misconceptions about what happens to the pelvis and leg length and then how to interpret it. So along with the technical stuff that I'm going to give you, I'm going to give you a lot of my own opinion too. So just be ready for that. And feel free to comment at any time. I can't see any chat, so either Marcos, you'll have to kind of sub in for me, or if you want to just unmute yourself and you can make a comment or ask me a question, feel free to do that. I don't mind stopping at all in the middle of anything that I'm talking about. So I'd first like to start with this image in complete anatomy, just to review some of our bony landmarks. So of course, here's the sacrum. Can you guys see my white arrow? Okay.
Yes.
Okay, so we call this the sacral base. And the sacral base basically is our foundation to the whole spine. So the Gonstead system is based on the foundation, and this is a big part of it right here is at the sacral base. And of course, that's where the lumbosacral joint is, and that L5 disc. So if we have a sacral base that isn't level, we need to address it if we can. Sometimes we can, sometimes we can't. But before you make decisions on if you're going to do anything about this sacral base, it has to fit certain rules. So you have to understand what the pelvis does to leg length, what the pelvis does to the sacral base, and what the pelvis does to the femur head height. I want you to look also at all the different angles. So this is the articulating surface of the SI joint. And then here's the ligamentous section, or the syndesmosis of the SI joint. So in reality, when we palpate the SI joint, we're palpating in this part of the joint. We're not near the articulating surface at all. And when we talk about pelvic misalignment, remember we said, well, let me ask you this question. If we have an AS listing on an ilium, and this is the PSIS where I have my arrow, which direction does that PSIS go? Superior, but it's also rocking down that SI joint. So if we have a PI, the PSIS then is going in what direction? Posterior and inferior, right? Okay. Now the next thing to think about, we won't even talk about IN or EX yet. But then we have this distance between that SI joint and the head of the femur. So what does that look like? It looks like about 3 inches, right? Because the head of the femur is actually sitting in a spot in that acetabulum where in the innominate bone, we have the ilium, the ischium, and the pubic bone coming together for the acetabulum. So you have to keep that in mind when you're trying to understand the mechanics of what happens to the femur head height with an AS misalignment or a PI misalignment. So let's start out just really simple. you don't have to understand this right now, but just put this in the back of your mind, that an AS ilium misalignment will raise the femur head. A PI misalignment will lower the femur head. Now I'm going to pan away and let's look at the whole lower extremity. Look at the angles coming down from the SI joint to the femur head, the neck. Here's the greater trochanter. Then we go down into the shaft of the femur. Now look at the femur. It's angling to the midline. And then we have to deal with what's happening in the tibia. And then we have the ankle and the calcaneus. So, all things being equal, if there's no deformity in the length of this leg at any part of the leg, we would say then that with an AS misalignment, it raises the femur head, but as it does that, because of these angles, these normal angles, we call them, one of them we call the Q angle, which is the quadriceps angle, it's going to lengthen the leg. So it does the opposite to the leg length as far as what the femur head does. AS misalignment raises the femur head, lengthens the leg. A PI misalignment in the pelvis lowers the femur head and shortens the leg length. Everybody with me on that so far?
Yes.
Okay. Then we have the IN and EX component possibly as part of your misalignment. So remember, with an IN, the ilium will misalign to the midline. So you would see more of the blade of the ilium. And if it misaligns externally, you're going to see less of it. So what happens, at the femur head height with IN and EX? Well, remember, IN goes with the AS, meaning that both at AS and IN they misalign anterior and superior up the SI joint. So an IN is going to raise the femur head just like an AS raises the femur head. The EX will do the opposite. EX goes with the PI as a married listing. So if a PI lowers the femur head, so does an EX. But then it shortens the leg. I wish I could get these bones to move so you could see that actually happening. Also look at how far anterior the head of the femur is to the SI joint. And then look at the shape of the ilium or the innominate. It's kind of bowl-shaped. So you have all those different angles, and that's why you get the effect of the femur head rising or lowering, and then it causing the length of the leg to just do the opposite. Anybody have any questions in that? I hope that was helpful before we get into the PowerPoint.
Yeah, Doc. Kevin asked, AS lengthens the leg and PI shortens the leg, correct?
Yes.
Okay. That's the only question we have so far.
Okay, and then we'll talk about it then too. You have what happens then to the femur head height and the leg length when you make a correction of that misalignment. So then everything goes in reverse when you do the correction. And if you understand that, then you're going to be able to understand measured deficiency and actual deficiency. That's when it'll click for you. Another thing to think about think of the superior aspect of the femur head with a plank running from one side to the other. And that'd be like a teeter-totter. So one person is sitting on the right femur head and another person sitting on the left femur head. And depending upon how we're going to make a calculation, the teeter-totter is going to raise and lower from one side to the other.
So Dr. Meisel.
Yeah.
So when we see a inferior tip sacrum on one side, are we contributing that more towards the ilium and the effect it has with the femurs and all that, causing a tipped sacrum as opposed to just an inferior on that side sacrum?
As far as the sacrum, like tipping, if it's going to be like the low side inferior, typically it would be on the side of the short leg. But another thing that can affect that, it would be malformation of the sacrum. The sacrum is probably the most malformed bone of the body. So if you are suspecting malformation of the sacrum and you see the ilium low on that side, you may or may not have to accommodate for that.
Okay. Yeah, because that a lot of times I just wonder why we see a tipped sacral base angle pretty much. Or just
most of the time it's malformation, but it also could be because you have enough of an anatomical short leg on one side, so the sacral base will be low on that side as well. So when we talk about heel lifts, whether somebody should or shouldn't have a heel lift, that will be something you'll want to consider.
Thank you.
Yep, good question.
Dr. Meisel, so if someone, let's say, didn't have an anatomically short leg and their femur head heights were equal, but they did have that malformed sacrum that was tipping it down on one side or the other, how would you approach that patient? Would you try and level out the sacrum, or since the femur heads are level, you'd leave it?
You never want to level off the sacrum unless it fits certain rules to be able to do it. There has to be other things going on to decide that, more than just the sacral base being lower on one side than the other.
Okay.
That's a quick answer to a complicated question. It'll make more sense when we go through a few more things for you.
Okay. All right. Thank you.
But yeah, that's a good question too, though. Yep.
Hey, Dr.
Anybody
Martin,
else?
One last thing to clarify. So if the sacral base is tipping on the side of the short leg, it's either going to be just a sacral malformation, an anatomical short leg, or a PI or an EX on that side as well?
Anything's possible, misalignment on a short leg or a long leg side. So that's what makes MD and AD so important to know how to do correctly, because what looks like a measured deficiency on the left, after you would correct the ilium, it might actually flip to have the AD, the axial deficiency, on the opposite side.
Gotcha. Okay.
So I never try to predict anything until I figured out AD and MD, or MD-AD first.
Okay, cool.
One of my goals after doing this with you guys is to impress upon you, or have you be impressed upon, the idea that you should never, ever base everything you're going to do the patient on a prone or supine leg check only. I mean, I can't tell you how many people I know that all they do for their chiropractic evaluation is a prone leg check, and then from there they assume that the short leg or the long leg, however it is they want to look at it, is the problem, and their goal is to balance the length of the legs, and then they think they're doing the patient a favor, and then they crunch everything from the bottom to the top end, and they think they've done something great. And they haven't considered all the things that need to be considered, because they could just be adjusting an anatomical short leg that'll never, ever be balanced. And the only way you're going to know that for sure is to take a film. So when we take our x-rays, trying to get my aliens to come back. There.
Doug, if you just hit the hide button right next to the right ilium, if you press that hide button, that should hopefully.
There we go. Whoops. Well, anyway, I got one of them. So when we take the x-ray, we want to make sure that we get the bottom of the ischiums on the film, and we want, of course, both femur heads. We do not care what the actual specific length of each leg is. We just want to know what the relationship is to the right and left femur head, and if there's a difference, how much difference is there, and then figure in what the ilium misalignment might do as well to the femur head, and then that's how we decide what the patient needs. So I think, unless there's any other questions, I want to go to the PowerPoint so I can clarify some stuff that you're thinking about, but just I haven't got to yet.
Wait, Doc, quick question.
Yeah.
I've seen some X-ray analysis with their software for the concept line drawings. They use the width of the most medial part of the ilium to the most lateral part, instead of comparing the distance from the pubic symphysis to the center line of S2 for the EXIN portion. How reliable is that compared to is it not as reliable for the number on the listing? Did you get what I was saying?
So you're talking about line drawings to see IN or EX?
Yeah, some systems have it where you just measure the width of the actual ilia and see which one's bigger or narrower, just like for our visualization. But they don't use from the pubic symphysis down to the vertical line from S2.
Oh, well, they should match. It should. I mean, unless there's
difference.
Unless there's big malformation.
Okay, I just didn't know if that affected like the millimeter amount difference.
It probably would. I try to go by what by the line, that's going through the pubic symphysis from the center of the symphysis pubis. That's what I use for my IN and EX.
Yeah, that's where it is. All of us in the chapters and stuff too. And I saw this once because I'm trying to find which X-ray to go with when we open. And this person was giving me a rundown, and he showed our software, and it was just taking the measurements of the ilia as opposed to using that line. So I don't know if that's as reliable for our normal.
I don't think they're going to match in millimeters, but it should match in saying IN or EX.
Yeah, but if we're doing MD80, a difference between an IN of 4 or an IN of 2, because it's just different scales. I didn't know.
Yeah, I go by what the line says, as long as you trust your positioning.
Okay.
If the patient's up there crooked and you see the glute, like say, let me turn this around. So here's the symphysis pubis, right?
Yep.
So if you see the gluteal fold, like, curving way over to the left or to the right of the center there, then you probably have the patient not positioned correctly on the film. If you see that big gluteal fold, it should be pretty close to the running through the center of that symphysis pubis. If it's not, then probably they've pushed or they're twisted a little bit one way or the other, and that's why the gluteal fold is bending over.
Okay. Thank you.
So when I position my patient, I always tell them, take little steps back until you just lightly feel your buttocks touching the bucky. Tell them, I don't want you pressing or leaning up against that bucky real heavy. I want you touching, but I don't want you leaning on it. Because that's what they'll do. They'll just rest their back on that bucky.
Yeah.
And then you'll get a big twist in their pelvis, and then you can't rely on it.
Mm-hmm. Gotcha. Thank you.
Yeah. So positioning is really important. So I'll tell you another thing. So like in school, in X-ray positioning, we don't teach full spine films, and so it's a sectional film, lumbopelvic, but they're concerned about seeing all the normal anatomy of the neck of the femur, and so to see the neck of the femur better, they tell you to tell the patient to internally rotate the patient's feet 15 degrees. Well, then that just throws off the whole biomechanical aspect of what you're trying to see, in the pelvis. So if you're going to do that, I would say then maybe you need to take 2 A to P lumbopelvics, one for the femur necks if you think it's that important, and then the other for, biomechanical analysis.
Dr. Johnny asked if the femur head is in the acetabulum, how does an X-ray show an anatomical short leg?
We're going to get to that in my PowerPoint. Good question. Should I switch to that now?
Yeah, that'd be perfect.
All right. This is only about 19 slides long, but it's packed full of a lot of information. Can you see my title page?
Yes.
Yes.
Okay. So on my title page, I just have an example of a pelvic listing, and then a measured deficiency, and then a calculation of the actual deficiency. We're not going to figure this out now, but I just kind of give you an idea of what you're looking at. So remember, this would be full spine, not just 14 by 17 if you're doing it the right way. But we've listed the left ilium as an AS5, IN5. Why would we have listed the left ilium and not the right ilium? Can anybody tell me? What decides which ilium you want to list?
The side of lumbar or body rotation.
Very good, Stephen. Yep. So if we had L5 here, it should be a PR something. PRS, PRI-M, or PRS-M, something like that. The body rotation has to be on that side. Why? Because 85% of the time, Gonstead felt that if there was an ilium problem, it would be on the side of L5 body rotation. That's a good clinical gem, right? That doesn't mean every time, but the high majority of the time, if there's an ilium issue, it's going to be on the side of L5 body rotation. So that's why you list it. AS and IN is a married listing. So that means we're going to add these subscripts. So that gives us 10. And then we have this thing called the 40% rule, and we're going to and we'll get to that in a second, but we're going to multiply 10 by 40%. That gives us 4. All right. So what does an ASIN do to the femur head? What did we say it does?
Raises it?
Raises it. So if we were going to fix that, then what would it do to it?
Lower it.
It would lower it. So remember the teeter-totter? So if you're going to lower the femur head by 4, what would that, on the left side, what would that do to the right side?
Raise it.
It would raise it by 4. So the measured deficiency initially was 10, but if we were to correct this ilium, in actuality, the actual leg length deficiency, when you compare not the actual length of the leg, but the top of each femur head, there's going to be a 6 millimeter difference. So now when you do a leg check and you see a short right leg of 6 millimeters, you know that patient, then that's that patient's normal. That doesn't mean that you need to adjust a PI on the right. That makes sense?
Yes.
So another way to calculate this too is that this is kind of tricky. When the MD is on the opposite side of the pelvic listing, for ease of calculation, you could just calculate the PIEX on the side of the MD, and you could figure it out that way too. So if we used PIEX, we'd say, okay, so what does a PIEX do to the femur head?
Lower it.
It lowers it. So if we were going to correct a PIEX, it's going to do what?
Raise it up.
Raise it up, and we said we were going to raise it up 4 millimeters. So you still end up with the same answer, 6 AD. Whatever is easier for you, however you to think about it, it doesn't matter as long as you understand. If you're lowering one side, you're raising the other. If you're raising one side, you're lowering the other. So there's our femur head line. And what we do is we take our, to get this MD line, we take our parallel and we put it at the bottom of the film. Because the bottom of the film is usually nice and square. Now in the old days, we used to have grid lines in the cassette so that you'd see these grid lines on the film, and so you could just pick a horizontal grid line, put your the leading edge of your parallel on that, and then scroll it up to the highest femur head. Then you take your pencil and you go over to the lower femur head, and then you draw a 2-inch line over the top of that, and then you measure that. That's your measured deficiency, and in this case, it was 10. So that's how you get that short line. Okay, so somebody was asking a question about how to know the actual length of the leg. Well, we don't need to know the actual length of the leg, but to understand why the femur head does what it does and why the length of the leg does what it does with misalignment, hopefully this will help. This comes right out of the chapters in chapter 3. So they're just using arbitrary numbers. So they're saying the length of the leg from the femur head to the heel, its vertical height on the left is 970 on both sides, and it's 1,000 on both sides on the femoral tibial line. So what that means is there is no leg length inequality, and there's no pelvic misalignment. So everything is equal. Everything is balanced. That almost never happens, but for theory, that's what we're saying there. So we have to consider these 3 things: the femur head height, the pelvic misalignment, and then are we dealing with an anatomical short leg or a physiological short leg? Physical therapists only consider a leg to be anatomically short if they see a short leg. Most chiropractors only believe that leg length is physiological, and everybody should be balanced with their leg length. And then I'm here to tell you, as a Gonstead practitioner, that they're both wrong. That it's a combination of both, and you need to know how to figure out if your patient has an anatomical short leg, and if they do, does it matter, or do they just have a physiological short leg? So the one thing that the physical therapists don't even consider is that pelvic misalignments affect femur head height and also the leg length, just like we were talking about on the skeleton. And then also, while correction of the pelvic misalignments affects then the femur head height and the leg length in reverse. And that's how we are figuring out the AD, the actual deficiency, after pelvic misalignment correction. So before using leg length as an indicator for patient care, knowing if a patient does or does not have an anatomical short leg is critical. I can't tell you how important that is. You can really mess somebody up by just seeing a short leg and throwing in a heel lift and say, go for it. That's just not good care. And certainly just visualizing a short leg in no way gives you enough information to know what to do with the rest of the spine above it. Because if you don't know if you're dealing with anatomical or physiological short leg, you're going to be wrong most of the time. This is, I guess, a summary of a leg length deficiency study that was done in July, or was actually published in July of 2019. And they concur what I saw in practice, and any Gonstead doctor that I've ever talked to, I'm sure would agree with this study, that 90% of our patients have a certain degree of leg length discrepancy. It could be anywhere from 1 millimeter to, a full centimeter, 2 centimeters possibly. And only 90% of the population has equal leg length, only 10%. So that means if you're using a prone or supine leg check to tell you what to do for the patient, you're wrong 90% of the time. So you got to do more than check leg length. In Gonstead, do we check the leg length? We do, because sometimes it makes a difference. But we are not deciding on that to help us decide what to do for the patient. It goes on to talk about the different amounts of leg length discrepancy related to low back pain, hip pathology, and knee pathology. And I found it interesting that they were saying that the short leg tended to give more low back and knee problems, and the longer leg side seemed to give more of a hip issue. Anybody have any questions on this study?
No questions in the chat yet.
Doctor, I actually have a question real quick.
Sure.
Did you ever found in practice any of this correlation whatsoever? That you said, okay, his leg is longer and the symptom is prevalent on an X amount of individuals, or not at all?
I would say that I agree that 90% of my patients had leg length discrepancy. I would agree with that if that's what you're asking me.
Okay, yeah, that was pretty much what I asked.
Yeah. I never really tried to keep track of if the leg was short, if they also had a knee issue on that side. I mean, I just always put it together. I didn't keep stats like that, but I know that 90% of my patients had one leg shorter than the other. And it varied from, very minimal to, maybe significant. So everybody was different, but very rarely did you ever see anybody with no leg length discrepancy. Very rare. This was done by PubMed and indexed by Medline. So it's a reputable peer-reviewed study.
Doc, also I wanted to ask you, you know how these people are like obsessed with the musculoskeletal system?
They're upset?
No, they're obsessed with the musculoskeletal system. Everything is muscle, everything is tissue, right? How much of that did you see to change once you did an adjustment at this level? Without needing to do any therapy or any muscle work or anything? I
don't know that I can give you a percent. it depends on how chronic their problem was. But, is that something that you as the chiropractor want to be involved with? Because it comes down to a business decision of, are you going to, do what you're specialized in, or are you going to have somebody else do the soft tissue work? Because if you do that soft tissue work, that takes away time from you from finding subluxations. But really, a muscle can only do one thing, and that's contract. So if it's contracting abnormally, it's never going to be normal, no matter how much you rub it or shake it, if you don't correct the underlying cause, which would be the subluxation. So certainly there might be a benefit to do both, but for you as the chiropractor, is that what you want to be doing?
Doc, did you also see that, would you always have the patient after you adjust them walk around instead of, because I see a lot of people, they'll adjust and keep the patient still prone, and then they'll check the legs right after, like instead of having them weight bear or move around and kind of see if it's going to hold,
I guess it depends on how important I think the leg length is for that particular person. Most of the time, I'm only concerned with it if I think there's a rotated sacrum on the same side of the ilium that I want to fix. I would say that's what I'm most concerned about it. I think your best check is your next visit anyway.
Thank you.
Yep. Okay, so let's talk about anatomical short leg. What does that mean? Well, that means that the actual anatomical measured length of the leg is deficient or short when compared to the opposite leg. That shortness could be in the femur neck. It could be in the femur shaft. It could be caused by rotation of the knee. It could be caused by the length of the tibia. It could be caused by an issue in the ankle. It could be even partially related to pronation of the arch. So we don't care what it is, actually, because we're not going to measure the length of the leg, but we're going to look at the femur head and compare the left and the right femur head to decide the difference in height at the femur heads, and then does that or does that not somehow affect the sacral base that the whole spine sits on. So trauma certainly can create leg length issues. I do have if you're interested in this short video link on this image on the left, it's about 38 seconds long. It's just showing a young doctor measuring from the ASIS to the medium malleolus, and then he measures from the umbilicus to the medium malleolus. And you can do that, but I still don't think that gives you as much information as if like you're going to get if you do it the way we teach it. But if you don't have an x-ray, I guess that's one way to do it. But hitting your landmarks exactly where they're supposed to be, and you're trying to figure out a difference in millimeters, that's pretty tough to do. If it's an inch different, a half inch different, you probably can see it with the tape measure. But if we're talking 2, 3, 4 millimeters, you know, how often are you going to be able to duplicate that every time you measure it? The more accurate way, if you wanted an actual measurement of the length of the leg, you would take a full leg, bilateral leg x-ray, including the pelvis. Well, not too many radiologists like this, right? They're all worried about radiation, right? But you can see some examples here of how different things can affect the length of the leg. Look at the knees, how that can affect the length of the leg. Male and female pelvis, there's a big difference in those angles as well. Another thing that can happen is patients will come in with hip replacements. Well, after a hip replacement, you remember they give a whole new socket if it's a total, a whole new socket and a new femur head and neck. So let's say initially they had a short right leg of 5 millimeters, and then they had hip surgery and they came in and you took a new film, and now all of a sudden, because their measurements and how they did what they did, now it's short on the opposite side. Well, that could create some big problems for that patient, because now their weight bearing has totally changed. The top of the femur head is here, not up here. Anybody have any questions on this slide?
Nothing yet, Doc.
Okay. All right, so let's get back to what misalignments do to the femur head. So we said an AS ilium and an IN ilium, that if they were together, they'd be married. So by themselves, they do the same thing. They raise the femur head. And then at the same time, because of the angles, as the femur head goes up, the length of the leg gets longer. ASIN, both raise the femur head and then lengthen or lower the leg length. Hopefully that makes sense to you now, and hopefully if you bring it to memorization, you'll be able to calculate half of what you need to know for ADMD. So here's some examples. We're saying there's an AS misalignment on this right ilium. What would that do to the femur head? What does AS do?
It raises the femur head.
It raises the femur head, right? Okay. And 40% of 5 is 2, so it's going to raise the femur head 2 millimeters. If it's an IN, it's going to do the same thing. Raise the femur head 2 millimeters. All right, the opposite. We have a PIEX or a PIEX. They're both going to lower the femur head and at the same time shorten the leg length. Everybody should be able to remember this one, because as soon as you see a short leg, they teach you PI in school, right? So this should make sense to you. So we're showing a PI and an EX of 5. The 40% rule says that for every 5 millimeters of pelvic misalignment, you get 2 millimeters of femur head height change. So the PI or the EX will lower the femur head 2 millimeters. And if that confused you, maybe this will help. So ASIN, what do they do to the effect of the femur head? They raise the femur head. PIEX, what do they do to the femur head? They lower the femur head. And what happens to the femur head when we correct it or adjust it? If we were going to adjust an AS or IN, then it's going to lower the femur head. And if you can remember that, then that is going to help you understand what the actual deficiency will be. PIEX, once you correct it, it's going to raise the femur head. So the 40% rule says that for every 5 millimeters of AS or IN misalignment, the femur head is raised 2 millimeters. For every 5 millimeters of PI or X misalignment, the femur head is lowered 2 millimeters. Hopefully you're getting tired of me saying that. You got it. But then when we correct it, pelvic correction says, for every 5 millimeters of AS or IN pelvic correction, then we're going to lower the femur head by the same amount. For every 5 millimeters of PIEX pelvic correction, then it's going to raise the femur head. So you got to remember the difference between what the listings cause as a misalignment and then what the listings have in effect to that misalignment at the femur head. Anybody need that clarified or repeated in any way, shape, or form?
Seems like everything's good.
Everybody's good? All right, good. All right, so here's a scenario with an anatomical short leg. So the short leg is not due to anything with a pelvic misalignment. It's an actual leg length deficiency. So we have these two lines, right? We have the vertical line, and then we have the femoral tibial line. Here's a physiological short leg with no anatomical short leg. So if we have a PI on the right, so there's a PI on the right with no anatomical short leg, what happens? Well, it's going to lower the femur head. PI and an EX will lower the femur head. And then also the vertical length will shorten. Same scenario on the opposite side. So if we have a PI on the right, we're going to have an AS on the left. What does the AS do to the femur head? It raises the femur head. And then what does it do to the vertical length of the leg? It lengthens it. Right, so rules for correction. For every 5 millimeters of AS or IN correction, the femur head will be lowered 2 millimeters. For every 5 millimeters of PI or EX correction, the femur head height will be raised 2 millimeters. So here's an example. AS 5, IN 10. We could add that and say 15 times 40%, or we could say 40% of 5 is 2, and 40% of 10 is 4. So that would give us 6. So the total effect of AS5, IN10 ilium correction would be to lower the femur head, because we know the misalignment raises the femur head. So if we're going to correct it, we're going to reverse the direction. So we're going to lower the femur head by that subscript that we figured out as 6 millimeters. The opposite, but same subscript, PIEX. PI correction raises the femur head 2, EX correction raises the femur head 4. So we're ending up with 6. So if we're going to correct the PIEX, we're going to raise the femur head by 6. Anybody not see that? Understand that?
I think we're good so far, Doc.
Awesome. Fourth quarter is going to be so easy for you guys. All right, so this is a kind of a good little side rule to remember. When you're calculating a mixed listing, so that means like a PIIN or an ASEX, if the subscripts are similar, so let's say you have a PI5, IN5, what happens is then little effect happens at the femur head height because they cancel each other out, unless, that's a big one, unless one of the subscripts is significantly larger than or dominant than the other. So let's say we had a PI2 and IN10. Well, the IN would be the dominant subscript in listing, so that would have the dominant effect on the femur head height.
So, Doc, would you also say that this is also another reason why just relying on the leg check can lead you in a wrong direction? Because if they are opposite listings, the leg will look even to them, maybe sometimes.
Oh, absolutely.
So
Absolutely.
You're subluxation there too.
Absolutely. Yeah. It just, looking at a short leg and having that dictate what you do is, 90% of the time just sending you down, a wrong direction. You can make a short-term physiological change to an anatomical short leg, but have the patient walk around, come back and check their leg length, and it'll be back short again, because it's not a physiological shortness. Or you could make a short leg shorter. How about that? Then what do? So this just takes out all the guesswork, I guess is the best way to say it. So you want to subtract the smaller subscript from the larger subscript and then multiply by 40, which is your 40% rule, to determine what we call the DF, or the distortion factor, or another way to describe it is the correction. We've been using the word correction, but that 40% calculation is determining what we call a distortion factor. Oh, by the way, too, this 40% rule is based on taking your A to P full spine film from 72 or 84 inches, not 40 inches. So I'm pretty sure that if you are taking 14 by 17 at 40 inches, you're going to have to talk to your X-ray tech guy to figure out a different calculation for that 40% rule, because the distortion totally changes by being closer with your FFD and you're not taking full spine. So this 40% rule probably won't make a lot of sense in your calculations if you're not doing it the way it was set up to be done.
Dr. Meisel, do you think then that maybe some of these doctors that are using the shorter focal distance are like coming up with the wrong listings and adjusting the wrong things if they're still using this analysis?
Certainly they probably are coming up with wrong MD and AD correction. Yep.
Okay.
I'm pretty sure you have to do some cephalic tube tilt, I think, at 40 inches. And I'm not. I know there's some guys that are that have talked to X-ray tech people, the people that install the machine, and they've helped them out with figuring out the formula.
Okay.
I think that's a pretty big deal, actually.
Doc, do you see that to be with digital and analog equally? Because again, when I talked to that guy, he was saying that the way they have their megapixels or whatever, it doesn't matter where you shoot it from. I don't know.
Well, I think that's worth discussion and debate. I'm not sure. I would think it matters.
Yeah.
Okay, so here's another example, but this is a mixed listing now. So we have an AS2 EX7, so we know that those two listings are opposite. So we're going to subtract 2 from 7. We get 5 times 40% is our 2 millimeters of distortion factor. So the predominant subscript was EX. So when we correct an EX, what's it going to do? It's going to raise the femur head by how much? Well, in this case, we figured out 2 millimeters. Another example, we're going to switch the subscripts but keep the same listing, AS-EX, but the AS is going to be 10, EX5. Subtract 5 from 10, we get 5 times our 40%, gives us the same 2 millimeter distortion factor. But we know when we correct an AS, we're going to end up lowering the femur head, and by how much? Well, by the 2 millimeters that we figured out from our 40% rule. Here's a PI-IN mixed listing. So the predominant listing is IN with a subscript 7. So 7 minus 2 gives us 5 again. I'm keeping the numbers simple here just to understand the concept. Times 40% gives us again 2 millimeters. So the predominant subscript would be on the IN. If we correct an IN, it's going to lower the femur head, and by how much? Well, we figured out 2 millimeters. PI 10, IN 5, so we're going to subtract again 5 from 10 times 40% gives us our 2 millimeters. The predominant misalignment with the subscript, or the largest subscript, is the PI. So if we correct the PI, we're going to raise the femur head by how much? By the 2 millimeters we figured out from the 40% rule. Anybody not understand those calculations?
We have a question. Jenna asked, if the femur head raises, how does the leg length become longer?
It goes back to what I was trying to show on the complete anatomy skeleton. Remember, the femur head is in front of the SI joint, and it's in front and below the SI joint, and then you have the Q angle from the femur head all the way down to the tibial plateau. So all those angles come into play in the shape of the pelvis. So if the femur head goes up, it's a rocking motion. The femur head goes up, it's going to lower or lengthen the length of the leg. I know that's a hard concept to accept, so go back and look at the anatomy, and that hopefully would clarify it for you. Anybody else?
And that's it for everyone.
Okay, I hope I answered that question for her. Okay.
I have a question, Dr. Meisel. Hello.
Go ahead. Yeah, go ahead.
Let's see that I know that we don't focus or look for leg length, but let's say that the leg length of the patient X is even, no? But the pelvis is misaligned. And when we correct now the patient have a leg discrepancy. With the discrepancy of the legs not misaligned, the pelvis again make it not hold the adjustment. I don't know if it's a basic question or confusing question.
No, that's okay. So basically you're saying in their subluxated state, they have equal leg length, and then if you correct the subluxation, you actually create a leg length deficiency, and you're wondering if that's good or bad, right?
Mm-hmm.
Yeah, so
yes.
The body can, Gonson felt the body could compensate for around 6 millimeters of actual deficiency without it being necessarily a problem. Meaning that if it doesn't affect the sacral base, meaning if the sacral base still stays pretty level, then that's just that patient's normal. Because you wouldn't want to have somebody that had a short left leg, anatomical short left leg of 4 millimeters, but their sacral base was level, and you just want to make sure that they have equal leg length and then give them a 4 millimeter lift, you actually would jack up that sacrum on that side and probably create a problem for them. Somebody's got a bird in the background. Did that answer your question?
Thank you, Dr. Meisel.
Yeah.
Yes.
Is that Jonathan?
Thank you all. Yes.
Yeah, hi Jonathan, good to hear from you.
Hello from Puerto Rico.
Yeah, oh wow. No kidding, you're talking to us from Puerto Rico?
Yeah.
Oh my goodness. The wonders of technology.
Thank you so much,
right?
Dr. Meisel.
Yeah, hey, I hope it's going well for you. Is it going good?
Always learning from you and for my club. My buddies here in the Concept Club. Thank you so much.
Awesome. All right. Anybody else have a question?
We're good so far, Doc.
Okay. So you want to perform calculations for the actual deficiency on the MD side. So remember that first picture on the title page where I had the MD on the opposite side of the listing? I said that's when it's kind of tricky. So here's kind of how you can handle that. when the listing is on the opposite side of the MD, just like you saw on the title page, you could convert the listing to the MD side to simplify the calculation for the AD. If you're having trouble visualizing that teeter-totter effect, then go ahead and just use the opposite listing, the one that's going to be on the same side as the MD, and figure it out that way. I'll give you some examples here coming up. So if the MD is 3 millimeters on the left and the listing is AS to IN4 on the right, then we want to convert that right ilium listing AS2IN4 to a left PI2EX4 because that's the side that the MD is on. And that might make it easier for you to calculate the AD. Now, by doing that, it doesn't say to change the side of the listing. You're just doing that as a mental exercise to help you keep straight on how that femur head is going to behave upon correction to give you the correct AD. And you'll want to star this down, write this down, because this could help you on a test question. When the predominant subscript is PI or EX, and the distortion factor is larger than the MD, the difference is going to be a negative number. So again, think of a teeter-totter. So let's say we had MD of 3 millimeters on the left, and we had a PIEX on that left side. And after we did the calculations, we ended up with that we needed to raise the femur head 4 millimeters. So that's more than the MD. So that would create a negative number on that left side. So in actuality, what happened was then the AD got flipped over to the right side. Anybody not understand that?
So far, so good.
Okay. So when the difference is a negative number, the AD is going to be on the side opposite the MD. So here's a slide to show you how to draw the lines. We kind of talked about that. We're going to use the bottom of the film as our level horizon. We're going to scroll up the parallel up to the higher femur head. And we're going to go over to the top of the lower femur head and draw our 2-inch line. That's our MD line. We're going to measure that distance from the top of the femur head to that 2-inch line. And in this case, we're saying it's 3. And then we're going to perform the calculation for the AD. So let's just do that. So is that a married or a mixed listing? AS2EX7.
Mixed.
It's mixed, okay? And what are we going to do with these subscripts?
Subtract them.
We're going to subtract them. So 7 minus 2 gives us 5, doesn't it? And 5 times 40% is what?
2.
2, okay? So what is the primary subscript? It's the EX. So if we correct an EX, what does that do to the femur head height?
It raises the femur head.
It raises the femur head. And how far is it going to raise the femur head in this case? We said it was what?
2 millimeters.
2. So if we have measure deficiency of 3 on the right, and if we correct this ilium misalignment, it's going to raise the femur head 2 millimeters. So that gives us an AD of 1. Did anybody just have a eureka moment?
This is just something that takes, I think, again and again and again to get. Because now that we're hearing this for maybe the 3rd or 4th time, it's finally starting to settle in.
Okay, yeah, that's the case. That was the case for me too.
Johnny said, how would an anatomical short leg differ from a functional in this picture?
Well, the MD tells us that there's a potential anatomical short leg. We just don't know how much, right? So that's why we figure out the effect of the ilium misalignment on the femur head. So we figured out that this person actually has a short right leg of 1 millimeter compared to the other side. We don't know the exact length of each leg, but we do know that the right one, if the ilium misalignment was corrected, is actually anatomically shorter. That's the AD of 1 millimeter. Did that answer your question, or did you understand that, Johnny?
He said, not really.
Not really. Okay. So do you understand what MD is?
Huh?
Yeah, John,
Okay.
do you understand what MD is?
Measures the deficiency with it. Not really.
Measure deficiency, right. Okay, so we don't know if that measured deficiency of 3 millimeters, if it's anatomically short 3 millimeters, or if it's physiologically short.
All right.
We just know, remember, this is a standing weight-bearing x-ray. It's not laying down. So we're just comparing the top of the right femur head to the top of the left femur head, and we're saying, well, there's a difference of 3 millimeters. We don't know if it's anatomical or physiological. So that's why we have to look up at the ilium and calculate from these subscripts what the effect would be at the femur head if we corrected it. So we figured out that if we corrected an AS2 EX7, it's going to raise the femur head by 2 millimeters. All right, so if we had an MD of 3 and we raised the femur head 2 millimeters, we end up with 1 millimeter left. So we can say with significant certainty that this patient, after this ilium would be corrected, should have an anatomical short right leg of 1 millimeter compared to the other side.
Okay. So you have to take multiple x-rays, not just one.
No, you don't have to take multiple x-rays.
So how would you know if you adjust the ilium if the leg goes back to normal? Like, how would you?
Well, you can do a prone leg check and you can measure it that way. You can take another film if you want, for sure. You can do that, especially if you think there's a rotated sacrum involved and you're trying to figure that out. You certainly can take another film for sure.
All right. All right. Thank you.
Yep. So on this slide, I've drawn all the dots, all the lines. We have L5 body rotation on the right. So we're going to list the right ilium PIEX. How did we get the PI5? Well, we measured the length of the ilium from the iliac crest down to the ischium. That's 145 millimeters. We measured the length of the innominate from the iliac crest to the ischium on the left side. That's 140. So the difference is 5 millimeters more on the right. So that's why it's PI, because remember the PI will lengthen, give us the visual image that it lengthens the ilium, where an AS will shorten the length of the ilium. And then the EX is determined by the sacral center line that Marcos and I were talking about. We measure the distance from that sacral center line to the center of the symphysis pubis, which is 5 millimeters. Also, that line will run through the EX side of the ilium. So it's showing an EX on the right. And then another way to tell if it's IN or EX is to measure. It's pretty hard. It doesn't really look like it matches on this schematic. But the width of the ilium should be narrower, right, on the EX side. But the obturator will be larger. So there's our listing, PIEX. That's a married listing. There's our femur head line. There's our line to measure the distance from the top of the opposite femur head to the top of the lower femur head, and we measured that, and we're saying that's the measured deficiency of 4 millimeters. Now we need to calculate the actual deficiency. So married listing, we add those numbers. We get 10 times 40% is 4. So if we're going to correct a PIEX, what does it do to the femur head? To correct it?
It lowers it, but to correct it, it goes up.
It raises it, yeah. So a PIX will lower the femur head, but upon correction, it's going to raise the femur head, and by our 40% rule, we're saying it's going to raise it by 4 millimeters. So that's going to make the actual deficiency 0. So that means this patient should have no leg length deficiency on either side if you've corrected this PIEX. What if instead of the distortion factor being 4, what if it came out to be 6? Then what would be the AD? It'd be 2. Go ahead.
Would it be 2 millimeters?
2 millimeters on the opposite side, wouldn't it? It'd be 2 millimeters on the left. Because if you go up 6, like a teeter-totter, if the right side goes up 6, that's more than the 4, so that means it's going to be lower on the left. So you'd have an AD of left. So here, that would be a situation where after correction of the ilium, instead of having an MD of 4 on the right, you'd have an AD of 2 on the left. Okay, this is just a worksheet. I don't want to wear you out tonight because I want to have enough time for you to listen to Dr. Burns. But here's different scenarios of where the ilium listing is on the side of the MD, and then based on that listing, I've already calculated for you what the AD would be and what side it's on. But let's do number 5, because this is one where the pelvic listing is on the opposite side of the MD. So is PIEX, is that a married or mixed listing?
Married.
Married?
It's married. So what are we going to do with those subscripts?
We're going to add them.
We're going to add them. So 5 plus 7 is 12 times 40%. And I always had a calculator next to my view box just because I didn't want to have to figure that stuff out in my head. So we get 4.8. So you could round that up to 5 if you wanted to. But let's keep it at 4.8 just for the sake of continuity. All right, so here's our femur head line. And the MD is 6 on the right, but the listing is on the left. So what we said we could do would be, instead of thinking PIEX, let's think ASIN over the MD side. The 4.8 is still going to be the same, but correcting an IN would do what to the femur head?
Lower.
Drop it.
It would lower it, right? So we're gonna lower a 6MD another 4.8, which gives us a 10.8 AD. So in this case, we actually made, by fixing the left ilium, we're gonna make that short leg on the right even shorter, because then that means its actual deficiency is 10.8 millimeters on the right. Now, if that's truly the case, that might be enough of a deficiency that maybe you need to do something with a heel lift on the sacrum, because maybe the sacrum is dropped on that side as well. So what are shoe and heel lift considerations? Just remember, it's a big deal to the patient. And especially down here in Florida, I would think if you're going to do that with a patient, you might want to do it through foot levelers with sandals, because people don't like to wear shoes down here. So it's pretty hard to have a heel lift in a sandal where they can just build it right into the sandal. But as a rule, the pelvis can compensate or accommodate up to 6 millimeters of actual deficiency. The actual deficiency becomes a problem when the sacral base becomes affected, causing a pelvic lowering on that side that could cause a scoliosis or a convexity of rotation to that short leg side. So number one, never put a lift in a lumbar, or never put a lift if the lumbar scoliosis convexity is on the opposite side of the low femur head. So if you had a short right leg, but the convexity of the scoliosis is on the left, you wouldn't want to put a lift in the right shoe. It'd make the scoliosis worse on the left. Never put in a lift if the lumbar vertebral bodies have rotated to the opposite side of the low femur head. So you need to see the lumbar body rotation on the same side of the short leg. If it's not that way, then it's not gonna work. And if somebody needs more than 7 millimeters of lift in their shoe, you got to put the rest of it on the sole. Don't put any more than 7 in the shoe, because then their shoe won't fit. Here's some examples of...
Meisel, can I stop you real quick?
Yeah, go ahead.
On the previous slide, I think I got 2 questions. You mentioned, it says vertebral bodies. So are we talking about more than just L5? Remember saying that?
Well, you certainly will look at L5, and then you want to look at the rest of the lumbar spine too. Because what if you had a special fifth lumbar listing?
Yeah, that's kind of what I was wondering. Like how, I didn't know if it was L5 is really the one we're looking at, or if we need to examine all 5 each time.
I think you got it. Well, L5 for sure, and then you also got to consider the rest of it too.
Okay, so it's just taking it all into account.
Yep.
Okay, and then just to try and give an example that we're all familiar with because we just did it. So on the practice calculations, number 5, the femur head dropped on the right side. So to follow that second rule again, it would have to be, we would have to see the body rotated right on that side if we were going to consider a heel lift, right?
Yeah.
Okay.
You would want to see the lumbar convexity of the scoliosis on that side, and you'd want to see body rotation on that right side.
Right. Okay. And then for the heel lift sizing, do we only order up to 7 millimeters? Or once we pass 7, do we order it to fill that whole difference, whether it's 8, 9, or 10.8, whatever that is?
So I would use the ones that could go easily inside a shoe. If it was 7 millimeters or less, and then if they needed more than 7, then I knew, and they're hard to find now because people throw shoes away. They don't get them repaired. But there used to be shoe repair stores that they'll add height to the sole of the shoe.
Right.
And if you can't find that, then I would use foot levelers, because you can buy shoes and sandals through foot levelers, and they'll put the lift on the sole for you.
Okay. I guess my question to further clarify is how do we know how much more, if we're going to order a heel lift more than 7 millimeters, how do we know how much more to go?
question. So let's say that you, here's two examples of where heel lift would be indicated. And we think they need 8 millimeters to take care of the leg length deficiency, and also to make sure, so look like on this one, the left side of the sacral base is a little lower than the right, which matches, that's the same side as the short leg. And it looks like the body rotation and the skull, a little bit of curvature is on the left, so that's why it's indicated. But if I want to know for sure how much to give them, I would put the lift in their shoe and then take a new picture with the lift in the shoe to see what it did to the sacral base and to see what it did to the lumbar spine. If it did
8 millimeter,
I wouldn't order 8 if it didn't need it.
but I'm saying in this instance.
Yeah, so say for example, so you'd have to somehow get that extra, maybe after you took the film, before you're thinking they need 8, but after you took the film with 7, it looks good, then go with the 7.
Okay. So it's
Or if it looks like, gosh, 7 didn't change it much at all. Maybe I need to go to 10 or 12. Well, then go ahead and just put that in the shoe just as a temporary thing to take an x-ray and see if it does what you wanted it to do to the sacral base and the lumbar spine. Because that basically is what you're looking for. You could care less if they have one leg shorter than the other. What you're worried about is what does that shortness do to the sacral base and the lumbar spine. So the idea that your goal is to balance leg length is ridiculous. What matters is what happens at the sacral base and at L5, L4.
Okay, so you just got to use clinical judgment and experience to figure the right size out.
Right, and then you have to figure out, oh, gee, I looked at their feet and they're pronating too. Well, okay, that can play a role in how much of a shortness. So maybe what you want to do is hold off on the heel lift and get them in arch supports initially instead first, and then see what that does.
Would you attempt to, before, if you're thinking about ordering heel lifts or arch supports or anything, would you adjust all the necessary joints that could be affected first? Make sure those aren't actually, the arch isn't lost or there's not a tibial rotation or something? Adding any millimeters?
Sure, you can adjust the arch, but it's going to take a while for that arch to make much change for you. And the orthotic can make a quick change.
Okay. Cool.
Patients they're not patient. They want results, right? So you got to try to do as much as you can with that, as conservative as you can to get the best result.
Okay, cool.
Good questions. Yeah, that's all just clinical stuff that it's not all black and white. You might have to play with it a little bit.
Right.
But you know what? You're the only one in the profession that's even thinking about it. Your physical therapists aren't thinking about it, and the diversified docs aren't thinking about it. They're all trying to pound the PI ilium to make the short leg balanced. So on the image on the right, we're showing a 11 millimeter actual deficiency on the right. We have lumbar body rotation on the right, and we have the convexity of the scoliosis on the right. So it would make sense that possibly a lift might be beneficial. Would they need the full 11 millimeters? Probably not. Maybe they only need 5 because you're just trying to get the sacrum level. Your goal is not to balance those femur heads. Get that out of your head. Your only goal is to try to get that sacral base level. That's it. And the last slide here, then we can be done with what my presentation, and we can ask some questions and get to that Dr. Burns tape. But here are two cases that would be contraindicated. So you have a short right leg axial deficiency, looks like a 1. Measured deficiency of 9. But look, it looks like there's malformation here on L5. Looks like it's a wedged vertebrae creating a scoliosis on the opposite side. You put a lift on that right side and jack that up, you're going to create a problem for that patient. On figure 67, same thing, contraindicated. You have an axial deficiency, if I'm reading that right, of 9 after the correction. But look, the scoliosis is on the left and body rotation's on the left. If you put a lift on that right side, you're going to make this worse. So even though you see that, you don't want to give them a heel lift. Even though you see this, you don't want to give them a heel lift. Okay, that's it. I hope that was helpful.
No, it definitely is. I mean, just to get it again and again. I mean, it's just something you have to drill into your head. It might not be the most interesting topic, but
hopefully I didn't put you to sleep.
No, it's not. It's just hard for people to really stay focused, but it's so important, and it makes a difference for patients for sure.
Anybody have any questions or any slide they want me to go back to? Or are you all begging to do something different now?
You guys can ask questions in the chat if anyone has any too. I can ask it. Doesn't look like anyone has been saying any questions, but thank you for going over this again, because it's again, it's so important, and people overlook it a lot, you know.